And we'll first hear a little bit from Dr. Andrew Williams, our Executive Director for the PQC, and then
Hey,
I'll take
everybody.
it from you.
Oh, sorry, Morgan. Hey,
No, you're
everybody.
good.
Good to see everyone on the call, and thank you so much for joining us today. As Morgan said, my name's Andrew Williams. I'm Executive Director of NSDPQC and Assistant Professor at the School of Medicine here at the University of North Dakota. Morgan kind of obviously runs a lot of these learning sessions and does a lot of the more on the ground work. So very happy that everyone is on the call today, involved in the PQC work at your hospitals and facilities. We're just really excited to be getting more active in the region since we have now some more permanent funding. We also have some students on the call today that we've been able to hire that are contributing to our efforts as well. So we're really excited about the future of the PQC. And that's all I wanted to say. Let's just say a quick hi. Yeah, excited for this learning session. So I'll just turn it back over to Morgan.
Fantastic. Well, welcome everybody. This is our first learning session for the Substance Use Disorder Initiative, Improving Care for the Maternal-Infant Dyad for our PQC. And like Andrew said, we are so grateful for all of the hospitals and facilities that are participating in all the work you and your teams are doing to help improve care across North and South Dakota. I'm going to just run over the agenda real quick, and so you can kind of see what we have on the agenda today. So first, we'll hear from Christy Johnson. I know some of you guys know her already, but and Dr. Kendra Joswak, Lindsay Carlson. I will give a quick update on our data and where we're at. Dr. Stephanie Foudy, Professor Heitkamp, Kim Miller, and Rebecca Hahn. And then at the end, we should have a few minutes for general questions. We'll open up for questions after each speaker because some people need to hop off right after they present. But that lasts probably, we might have 5 to 10 minutes. We can use, if any of your hospital teams have questions to the group about maybe data collection or what other teams are doing, we will have time for those questions as well. And you can also pop things in the chat and we can answer them that way as well. While we're on the topic of a chat, plug in where you are from, your name, what facility you're at, and we can see where everybody is from on the call today. But to start off, I'm going to stop sharing my screen and introduce our first speaker, Christy Johnson. We're so lucky to have her back with us. She was part of our September conference that we had in person at University of North Dakota. She was born and raised in the Twin Cities. Christy has been a flourishing Fargo-Moorhead resident for the past 8 years after rebuilding her life. Rebuilding a beautiful life for herself. For many years, Christy struggled with addiction and mental health issues, and now she spends her time utilizing her journey and experience to serve the community. Christy wears numerous hats in the community, not limited to being a peer support administrator for the North Dakota Department of Health and Human Services, as well as being support staff with Clay County, Minnesota Drug Court treatment team. Christy wholeheartedly enjoys sharing her lived experience and thinking outside the box in hopes of assisting others on their journey to wellness. The most important hat she wears is being a mother in recovery. In her spare time, she enjoys fun adventures with her children, exploring nature, and being tackled for cuddles by her chaotic fur babies. And Christy, I'm gonna have to see a picture of those fur babies, but I will mute myself and I will let you share your screen and take over.
Oh, Morgan, I could send you pictures of them all day. Thank you so much for having me, you guys. Morgan kind of broke down an awesome bio, kind of just of a quick little introduction for me. I kind of want to tell you guys about an awesome program that we have established in North Dakota in hopes of supporting moms that are pregnant or parenting that are kind of struggling with recovery / substance use. And one thing that I learned is whenever I present about Call K, it seems to kind of resonate with people more, especially in the healthcare field and, human service realm, when they kind of hear like the backstory of it and just how powerful hope and kind of cheerleading for people can really be. So I'm going to get kind of vulnerable with you guys and share a little bit about my personal story. You're going to see some lovely mugshots in the meantime, and then it kind of just show, how, again, kind of how powerful just little seeds can be when they are planted and become watered. So I am going to go ahead and share my screen. Let's see. All right. Can you guys see that okay? Okay, perfect. So this is just a short version, but it's a story about a girl and the birth of a phenomenal program called Call K. So when I was kind of brought into the world, I had, from the outside, a pretty normal life. I did end up kind of as, one of those kiddos that ends up in the foster care system, not really realizing that my parents had their own struggles, right? Mental health, addiction. But it was just kind of my norm. Like chaos was just kind of the thing for the majority of my childhood, honestly. And, my grandparents were kind of like the pillar of, they want to try to give me as much stability as possible. I kind of grew up always really yearning for, my mom to be in a healthy spot. Granted, I didn't really understand what exactly was going on. I just knew that she wasn't there, right? And so as I was growing up and I was becoming a teenager, that's me with my friend's son. Like my biggest goal in life was I am going to be a mom and I'm going to knock that out of the park. I always wanted to be the mom that I didn't have, right? The mom that my girlfriends would complain about, like, oh, she's so annoying. She's bugging me about my homework and she wants to hang out. Like I had always dreamed of having that mom. And and so I actually became a mom for the first time when I was 20 years old, about 20. And I gave birth to the most beautiful little boy in the world. And I'm sure you can tell in the middle picture, I was elated. My life was just beginning. I was young. I was, it wasn't the greatest situation. I wasn't married or, in a consistent relationship with his dad, but we were happy. Life was good. I was working, stuff like that. And then shortly after that, unfortunately, I was introduced to drugs, which actually had been meth at the time. And something about it took over and I could not stop. I wanted to. Every single day I wanted to stop. There was not a day where I didn't wake up and say, oh, I'd rather do this, versus being a mom. There was something about it where I physically and mentally, and this is addiction, I just could not stop. Right. And it got deeper and deeper and it got out of control to the point where, my son's dad knew something was going on, filed for, an emergency custody hearing because I got to the point where I would crave it so bad that, I would be like, oh, I can't pick him up today, and in my head, I'd be like, okay, I'm going to do better tomorrow. And it got to a point where I knew that he needed something that I was not able to provide him. And at that moment, I knew that I was following in the footsteps, of my mom, but then also feeling like, how could I do this, right? Like, what kind of human am I if I can't, if I made this decision, and I couldn't just stop to be a mom, right? And I'm sure a lot of you know that a lot of people that don't really understand addiction, some people would argue that it's a choice. I did not make the choice to wake up every day and choose drugs over being an all-star mom. And so after my son, and you can see in this picture, I looked pretty rough, right? And this was super deep into my addiction. These were during supervised visits at my grandma's house. This is actually one of the last times that I saw him. And this is also around the time where during my last visit, he kept crying because he didn't want to leave his mom, right? Him and I were very close before I entered my active addiction. And I had decided during my last supervised visit that it would be easier to just for him to not see me at all than for me to just pop in and out. Right. And when I say my addiction was very deep, it was very deep. And that's the beast of addiction. Right. And so after, I stopped seeing him, I had it in my head that, I'm going to get sober. I'm going to get sober. I'm going to enter recovery. And I wanted that every single day when I would use, that's all I could think about was how do I get out of this, And next thing you know, days turned into weeks, into months, into years. And I had, it got deeper and deeper. Most people would think, oh, well, not having your kids should be a motivator, but it's actually not, And so through the course of my active addiction, which spanned for about 9 years, I got pregnant. And then I would get pregnant again. And every time that I would get pregnant, the first choice was adoption, hands down. I instantly gave those beautiful kiddos a life that I knew I couldn't give them. And in my head, I was like, I don't deserve to be a mom. And if I ever can be a mom, I should be fixing things with my firstborn, right? And I was absolutely broken during those years, you guys. I was selling drugs and I was going in and out of prison and I was on high-speed chases, and it was just anything that you can imagine, I was probably doing it. And sorry guys, my grandma just figured out how to FaceTime and now she won't stop my phone. But so it was deep, right? And now the one thing that I really want to highlight is that through the course of my addiction, when I would get pregnant, every time I became pregnant, and I would want to be sober, but my rock bottom was ultimately not being able to stay sober while I was pregnant. And that to me in my head, I was a monster, right? I'm like, how could I not think of this innocent baby's life over my own? Like this innocent baby that is in my belly, you name it. I had all those horrible thoughts, and obviously there's a big stigma attached with that. When I used to sell drugs and I'd see a pregnant mom somewhere on the streets, I would just look at her like, God, you are just horrible, right? And then next thing you know, I'm deep into addiction and I'm that pregnant mom. And with my youngest daughter, this was in, I want to say 2013. I had a placental abruption with her. Obviously, I was avoiding prenatal care because, again, I had it in my head like I am going to recover. I'm going to stop. I just couldn't. I wanted to, you guys. It didn't work like that. Again, the beast of addiction. And I had a placental abruption with her, and I ended up in the hospital for an emergency C-section. And I had all these blood transfusions, and I remember waking up and there's this cute little old lady, and she was like, you have a gorgeous baby. You should go see her. She was in the NICU area. And I knew that they knew, right? They knew that I was under the influence. They knew that she tested positive. I already knew that they were aware of all of that. And so I went in there and there was a nurse in there, and my daughter's fingers were wrapped around the nurse's finger. And she looked up at me when I came in and she just shook her head. And that to me was it. I don't always share this part, but so I had warrants out for my arrest, and within about 15, 20 minutes of that, I was ripping IVs out of my arm and I got out of the hospital. And I ended up attempting to end my life later on that day because that was it for me. I knew when that nurse had looked at me that it was I was doing more harm by existing as a human than trying and lying to myself, saying I could come out of this and I could be a good mom, let alone get sober, right? But somehow, some way, I survived that attempt. And within 24 hours of that, I was picked up on my felony warrant. And what I did not know was that at the time, that would be the last time that I would ever be incarcerated. I initially did what a lot of people in the depths of addiction do, where they're like, yeah, maybe I'll go to treatment and, I can get back out on the streets and I'll cut down on my incarceration time. But what happened was when I went to treatment outside of Minneapolis, where I was growing up and did all my chaos, that there were some seeds planted. And what I started to do was I had it in my head that I would just put an ounce of the effort that I put into my addiction, into my recovery. There had to be something out there, right? But when I looked in the mirror, all I could see was a woman that had all these kids that didn't have custody of any of them, came from a broken home. I was the epitome of a statistic, right? And again, back to that stigma, there's a lot of assumptions that women like me that you end up seeing in those labor rooms and those court hearings for kids that are getting, your rights are getting terminated to, like my youngest daughter that I had the C-section with. People like us, normally most people would have to assume that, well, they're just going to keep doing that, right? And that's the stigma in the community, whether we like to admit it or not. And after I went to treatment, I knew that if I wanted to do anything, there's no way in heck that I could go back to Minneapolis, St. Paul. Some people could, recover in the same area. I was just not one of those people. I had to get away. And so kind of to fast forward a little bit, I ended up coming to the Fargo-Moorhead area to go to a halfway house in Dilworth. And I just wasn't sure I was going to keep doing it. I was like, okay, I checked the box, I'm probably going to go back to it because it's all I know, right? I'm in my late 20s or mid 20s, and that's the epitome of my life. The chaos and just the instability and the addiction is literally, I had it in my head that was my DNA and that's all I was capable of, right? Well, I had gotten a job when I was in that halfway house and met a guy, because that's just what we like to do when we enter recoveries. We get lonely and a little codependent, right? It happens. And I ended up becoming pregnant and still sober at the time. I had, I only probably had, a few months of recovery under my belt when I got pregnant with him. But again, instant thought in my head is, I don't deserve this. Yeah, okay, I'm sober. I'm doing things, but my intention of it wasn't like a long-term thing at the time that I knew of, right? I didn't know if I was going to be successful. I knew that I had a thought of believing in myself. I knew that I wanted to try. It was the first time that I didn't run when I was on probation. I followed through with treatment. I graduated treatment, so it had to mean something, right? I was doing something different. Well, when my son was born, my plan was to give him up for adoption. And now keep in mind, you guys, on paper, I have numerous felonies. I have all these kids that I didn't have custody of. There's just nothing on paper that shows anything good in my life, right? Hadn't had like a job in many, many years before my job in treatment, a legal job anyways. And so when my son, when he was born, I wasn't sure why, but I was like, I'm going to try this. I don't know. I'm just going to wing it and I'm going to give it my all and just see what happens. And so when my son was 7 days old, and keep in mind, I am sober, he was obviously tested. He tested clean. Clay County Social Services, where I was residing, came into my home while I was breastfeeding him, and they removed him from my care at 7 days old. And the reason for it was because, in the state of Minnesota, if you have a prior termination of parental rights, involuntary, they can, remove children from your care for the rest of your life. And that's what they did with my son. I had hoped that maybe they would look into things or, support me, whatever. But in their eyes, which is understandable, it was like, whoa, let's pump the brakes. We don't know how this is going to go, right? But and I should backtrack a little. They decided to file a termination of my parental rights immediately. Like it was embedded in my head from day one, like you will not be this child's mother. You should give him to a better home, and have you considered just, letting him have, a good life like the other children did, right? All these little seeds that were kind of planted because again, sometimes there's that, stigma deep down in, the community or workers or whatever that sometimes people really just don't think a person with a record like mine could amount to things, right? And so I kind of was trying to challenge myself a little bit, like, hey, I just did a few things that I've never done. I did treatment. I'm still sober. Because trust me, when I say that they walked out with my son, my first response was to just go use and relapse and numb all of my pain. But something about that situation made me want to fight. I also had a C-section with him due to the other one I had, with the placental abruption. And it was February. And I was walking to my supervised visits with him at the social service building in a blizzard because I was way too scared to be late and I just didn't want them to hold anything against me. And again, I was going to these visits not knowing if I'd ever be this kid's mom, right? And wanting him to have that life. But there was something along the way that that happened in my court hearings, and it kind of changed the trajectory for me, you guys. And I had a judge, she saw something in me. And that judge believed in me so much that I really started to believe in myself more. And, when I think of my service providers and I think of, the one little cute nurse in the hospital that was like, your daughter is beautiful, you should go see her. She had no judgments, right? She wanted me to enjoy that moment because I was that baby's mom. And when I think about this judge that, was telling me, okay, this isn't looking great for you, let's see what you got. Those little seeds, you guys, without those seeds, none of what you see on this screen now would have been possible. I have a beautiful life. I am a mother, a full-time mother. I'm doing great things in the community. And like the likelihood of you, probably thinking that this is possible, if you were one of my service providers back in the day, it wouldn't have looked great, right? We can cheer people on and you want people to succeed, but at the end of the day, you just never know what the trajectory of their life is going to look like. And so through my journey of recovery, I've also reunited with all of the beautiful babies that I gave birth to. They have great lives. It's kind of crazy to think, holy cow, like I feel like I have a Brady Bunch. I should have my own show, right? But great kids, great families, great lives. I get to talk to them whenever I want, FaceTime. It's a great situation, right? And so one of the things that kind of came to fruition throughout all of those pregnancies was that I was scared, right? Anytime I was pregnant and I wanted to get clean, there were a lot of assumptions that made it kind of harder, right? Not sure if I would have done it anyways, but there's moms out there that are pregnant that are scared to come forward because they're going to lose their baby, because they're going to get charged with a crime, all sorts of things, right? But the power in just a little bit of hope and believing in somebody can go a long way. And with all that, this whole timeline of my life, you guys, it wouldn't have been possible to have one little nurse just make a moment in the hospital possible for me and believe in me with no judgment, right? A judge that was like, yeah, okay, things don't look good, but let's focus on the now. Let's see what you're made of. Like, let's support you. And having those seeds, you guys, just changes everything. So the importance of having those seeds kind of led to discussions that started a program that I obviously is near and dear to my heart called Call K. Now, what Call K is it's a peer-ran resource that anybody can call day or night. Again, it's geared towards pregnant moms, so they can get connected to a peer support specialist with lived experience who can offer support and encouragement. So the whole purpose of this is we really wanted to establish a way where a mom, let's say she's pregnant and she's scared, where she feels comfortable reaching out, knowing that there's somebody on the other end of that line that knows what it's like and that knows it's scary to, become vulnerable and reach out. And the whole purpose of that is hoping that I can connect that mom with some resources to help her make a different decision. Okay, you want to confront the county because you're scared. Let's figure out how to do this safely in a way that you feel comfortable. You want to get connected to meetings or treatment. I will help you with that, right? I will champion you. And if you don't have anybody believing in you, I will do as much of that as I can, and we will just do whatever, right? I'm sure a lot of you have heard what peer support is. It's just a person that really has some similar lived experience and is living their life of wellness, in a good way, right? And peer support, you guys, it's rapidly expanding in North Dakota in so many realms, and not just addiction, right? We have it in the brain injury realms, we have it in the refugee realm, the veteran realm, all sorts of stuff. And so there's just unlimited studies that really show just how far the support of somebody that's been there can go. And again, kind of back to the fear, as a parent or a pregnant mom potentially struggling with substance use, it's scary, fear that somebody will automatically lose custody of their children, fear of stigma and judgment during prenatal appointments if using during pregnancy. This one is huge, you guys. I was lucky enough during my last pregnancy with my little girl to get connected with an amazing team. One of those individuals is actually on this call, non-judgmental and just super like, hey, yeah, we know about your past, but this is awesome. You're great. How can we support you? Some states carry criminal penalties regarding moms that use illegal substances during pregnancy. And again, back to that kind of the fear of the unknown. The whole goal of Call K, confidence in reaching out, providing a service that individuals can feel comfortable utilizing with the ability to build rapport, connection to resources, assisting individuals with navigating those resources, encouragement. This one is huge. You know, again, back to statistics, a lot of people that kind of end up in a deep cycle, they end up going to court for their kids and they don't have anybody in that courtroom because they might not have, you know, a good family in their background. You know, sometimes the polar opposite. I always look at it like any extra encouragement and support is better than none, right? Even if they have a lot. Back to that peer support thing again and changing the trajectory. Overall hope that Call K can assist parents, pregnant moms with another layer of support that could ultimately instill enough hope in them to work towards recovery or sustain recovery. And a big piece of that, you guys, is believing in somebody so much that they do start to believe in themselves. One of the things that I really like to kind of share about is, you know, I don't get a lot of calls from pregnant moms on this. When we first launched this a couple of years ago, it was just kind of stuck in Burley Morton. We wanted to see, you know, where it would go. But I will say this, you know, when I do get a call from a pregnant mom, I got one a few weeks ago. It was from a mom. She was texting me from a jail texter. And I could just tell that like she was ready. She wanted to try something different, right? And so when you think of it, okay, how many calls did you get this month, Christy? Okay, I got one call. But that mom is now in a maternity home in Fargo with plans to continue her life of wellness and raise her child. I have pregnant moms that I connected with in the beginning of the inception of the program who will text me a picture of their baby saying, oh, it's her first birthday, you know. And so when you think of the trajectory of that, you know, and, you know, just believing in somebody and providing them resources in kind of an unconventional way and how powerful that is, it's just, it's beautiful, you know. And so this was kind of our way of trying to think outside the box a little bit and really just kind of just put it out there, you know, and just hope that, you know, people will utilize it however they see fit. I got a call yesterday, a mom, she really needed some resources for diapers and like WIC. She didn't even know what WIC was, you know. A snapshot of Call K and just kind of a little backstory of like my personal connection to it and just, you know, how powerful cheerleading for somebody can really be. So, yeah.
Thank you so much, Christy. I love hearing the success stories from Call K, and your personal experience is just so wonderful. So thank you for being open and vulnerable with us
Yeah.
and sharing your story. So next we are going to hear from Dr. Kendra Joswak. She was born and raised in rural Valentine, Nebraska after completing her first degree in human biology and obtaining a certificate in clinical microbiology from the University of North Dakota. She worked as a clinical laboratory technologist in Mayo Clinic's mycology and mycobacteriology lab for 5 years. So wanting to directly impact the patients behind all of her lab samples, she earned her BSN from the University of Wisconsin. She started as a bedside nurse in Valentine's Critical Access Hospital, followed by 5 years of nursing in Mayo Rochester's Medical Surgical Transplant ICU after completing her nurse practitioner clinical residency with Mayo Clinic and earning her doctoral degree in 2017. She moved to Rapid City, South Dakota. Her nurse practitioner career has included positions in cardiology, urgent care practice, and addiction medicine. She joined Project Recovery in 2021, serving both provider and medical director roles. Her husband, 2 daughters, and 2 spoiled Bernedoodles fill her life with joy. And again, I'm going to need to see some pictures of all these little fur babies because they just sound
I'll send
so
you
adorable.
pictures.
Yes, please.
Thank you so much, Morgan. I appreciate the introduction. Welcome, everyone. I'm just going to share my screen here and get started. So let me know if that goes through. All right. So already been introduced. I am Kendra Joswak. It's so nice to be invited and participate in this. I'm so pleased with this important work that you are all doing and would love to be a resource with you throughout this journey. Morgan just gave me free rein onto what to talk about. So we're just going to kind of dabble in several little topics here. And in the future, if you're interested in a specific one, we can deep dive a little bit more. But we're just going to talk about opioid use disorder as a chronic disease, medications for opioid use disorder, what Project Recovery is and what we do here in South Dakota, and then our treatment approach in pregnancy. So a 2019 national survey estimated that about 1.7 million US adults suffered from OUD. However, this is likely a gross underestimate. It's closer probably to 6.7 to 7.6 million individuals. It's very hard to determine how many people really struggle with this. Opioid use disorder is a chronic disease of the reward system of the brain. The distinction that addiction is a treatable chronic disease is very important. Historically, addiction was viewed as a moral failing deserving punishment and remediation. Treatment was inaccessible to many and highly restrictive. Using opiate agonists was viewed as substitution or replacement therapy, which caused harmful stigma leading to inadequate care. So, like heart disease, cancer, and diabetes, addiction occurs due to a combination of genetic, environmental, psychological, and behavioral factors. Without adequate treatment using medication therapy, it will be progressive and it will kill people and cause significant disease. Looking at OUD through the lens of chronic disease management, we do not have a cure. We know that goals of treatment should be to prevent acute and chronic complications of the disease. A comprehensive treatment model using a chronic disease model, using medication, lifestyle changes, behavioral support, and social support is the ideal. When comparing OUD to other chronic diseases like hypertension, asthma, and diabetes, prevention and treatment outcomes actually have similar success and recurrence rates. This, if you take anything away from what I say today, it's this. Medication should be used as first-line treatment for OUD. Counseling alone just is not effective in reducing overdose and opioid-related morbidity. It doesn't mean it's not important, but it's not the most important. And this is my why, and this is our why here at Project Recovery. Unfortunately, 87% of people meeting criteria for moderate to severe opioid use disorder do not receive evidence-based treatment. Project Recovery was founded by Dr. Tamang in 2018. Dr. Tamang began treating patients with OUD in his primary care practice. He soon realized the tremendous need in our community for OUD. He quickly mobilized a team, including individuals from all facets of healthcare delivery, to create Project Recovery. Through the State Opioid Response Grant and contracts with Pine Ridge and the Tribal Opioid Response Grant, we were able to open our freestanding clinic in 2019. Medication and visits are free of charge for low-income individuals without insurance, meeting state criteria. We have established satellite clinics in Pine Ridge, South Dakota, and with Katota Prairie in Sisseton, South Dakota, and telemedicine visits are open to all South Dakota residents. We do embrace a harm reduction philosophy and adopt a low threshold approach to treatment, which we'll talk about a little bit more in a bit. We average about 1,000 monthly visits and have over 500 patients actively on buprenorphine therapy. As Christy well introduced for us too, we actually have CASET certified peer support specialists. These individuals are all in sustained remission from their use disorders and share their lived experiences. They support our patients at every single visit. Our addiction counseling program opened in spring of 2022, and through that pathway, we are able to get people to higher level of care. And just 2 months ago, we had our first group session. So we're really excited about that also. So 3 medications are FDA approved for treating OUD. Methadone, which is a full opiate agonist, buprenorphine, which is a partial mu receptor opiate agonist, and long-acting injectable naltrexone, also known as Vivitrol. Medications for opioid use disorder reestablish homeostasis of the reward pathways of the brain, in part by blocking the reinforcing effect of ongoing opioid use. They improve emotional and decision-making capabilities, treat withdrawal symptoms if using agonist therapy, and reduce opioid cravings. They improve patient engagement in addiction treatment. So our goals with medication for opioid use disorder are to improve overall physical and mental health, or to improve quality of life, to reduce drug-related and all-cause mortality, to reduce morbidity with particularly focusing on the reduction of infectious disease complications of IV drug use, to reduce or discontinue illicit opioid use and misuse prescription opiates, and to reduce drug-related crime. So we strongly encourage initiation and continuation of medication for opioid use disorder during pregnancy and support breastfeeding in those stable individuals on agonist therapy as per ACOG's guidelines. We do encourage you to connect anybody in the South Dakota area who's struggling with opioid use disorder our way, as initiation of medication, it could be life-saving for both mom and baby. Our OB/GYN colleagues may assist in identification of OUD through screening. Suggested screening tools are aligned in ACOG's guidelines and include SBIRT, the 4 Ps, and CRAFT. CRAFT is validated for adolescents age 12 to 21. Depending on the stability of the individual's recovery, we see them anywhere from twice weekly to monthly. This gives them multiple opportunities. Are you guys still there?
Yes, I can still hear
Okay,
you.
perfect. Sorry, it just glitched on me a little bit. So sorry about that. Are you seeing my screen still?
I can. It just says you are sharing screen.
Okay,
It's a
all
white
right,
screen.
thank you.
You're
Sorry,
right.
we just lost.
Technology. This is what we
No,
get.
we just lost connection. We have some internet issues here, so let me just do that again.
Oh, there we go.
All right, very good. Sorry about that, guys. So depending on
Hold
the
on,
stability.
it just went white again.
Shoot.
Do you want me to try to share my screen?
No, let me try one more thing.
Okay.
Yeah, if you wanna do, so we're at the OUD and pregnancy slide.
Here we go. All right, I will.
Sorry about that power failure.
Oh, you are just fine.
All right, so depending on the stability of an individual's recovery, we see them anywhere from twice a week to monthly. So this gives us here at Project Recovery multiple opportunities during the pregnancy to provide anticipatory guidance surrounding what neonatal opioid withdrawal syndrome, or NOWS, might look like, and to introduce expected hospital management approach. Recently here at Monument Health in Rapid City, the team did adopt the Eat, Sleep, Console method, and we have found this substantially beneficial to our moms. So we can advance slide here. So low threshold medication for opioid use disorder equals same-day treatment entry, prescriptions at the very first visit, home-based injections. It really embraces a harm reduction approach, which the patient's goals are prioritized, and the providers and the entire healthcare team take a non-judgmental approach to treatment. We really need to focus on visit flexibility. Counseling is offered at every single encounter, but it is not required. If you remember, very first thing you need to think with opioid use disorder is medication is your first line treatment. We also have encouraged people to engage in non-traditional treatment settings. If you came into Project Recovery, you would very quickly learn that this is not your average medical clinic that we all know. Low threshold treatment with medication for opioid use disorder has demonstrated a reduction in mortality, criminal activity, and infectious disease complications of use throughout the world. One barrier that has been successfully removed in January 2023, the X waiver was eliminated, which is amazing news, because now anybody who can prescribe controlled substances can now prescribe buprenorphine. There are some nuances to buprenorphine prescribing though, so I was actually very pleased when the DEA announced that an 8-hour training will be mandatory for all of those individuals too. As if you guys are pursuing this in your journey, please do reach out, as I would be happy to help you find the resources that were really helpful for me in establishing my practice and how to manage this medication. So one particular point that I want to make as you guys pursue improving practice throughout North Dakota and South Dakota is referrals. Referrals are wonderful, but sometimes it's checking a box. There is significantly poor follow-through with referral. If we go back to that addiction is a disease of the reward system of the brain, following through with pretty much anything is challenging. So a recent study in California demonstrated that individuals with substance use disorders receiving a referral to treatment without support to follow through on that referral, only 15% people actually were in a treatment program within 30 days. Of people who had navigation support to get people directly connected to care, that was greater. It was 50% of people were able to connect with care. So I really encourage you all to have a plan. You need to, if you move forward and if you're engaging in prescribing this medication, learn how to do it well. If you don't feel comfortable prescribing it, find a program that can see the patient rapidly, same day, even if possible, and educate yourself on how to connect people with those resources right then and there when they screen positive in your office or clinic. Next slide, please. So this question often comes up for us. What about our teen moms? We are seeing more and more of this across the country and adolescents as well. So OUD often begins in adolescence. You think about it, the prefrontal cortex is not fully developed till age 25. So this could have a huge impact on their overall whole person development and their safety. Mortality from OUD is rising in adolescents and young adults. Although buprenorphine is only FDA approved for ages 16 plus and Vivitrol only for 18 plus, the experts all agree that if they meet criteria for moderate to severe opioid use disorder, they should be offered full access to medication for opioid use disorder regardless of age, as this could significantly reduce lifelong harm, mitigate disease progression, and reduce mortality. Next slide, please. Unfortunately, if your area is anything like mine, polysubstance use disorder is all too prevalent. As far as pregnancy goes, we do have FDA-approved medications to treat alcohol use disorder. However, none of those medications are compatible with pregnancy or considered safe in pregnancy. We can assist individuals with counseling referrals, and that would be your first-line treatment for alcohol use disorder. As far as methamphetamine and cocaine, other stimulant use disorders, regardless of pregnancy status, unfortunately, there are no FDA-approved medication options available to treat stimulant use disorder. Primary treatment recommendations at this time for individuals meeting diagnostic criteria focus on psychosocial interventions. There are some off-label treatments that we have attempted when psychosocial interventions don't work, but those aren't considered safe in pregnancy either. Next slide, please. So Chrissy did a great job at sharing similar anecdotal themes that I've heard from my patients about their experience in the peripartum and postpartum worlds, as well as with healthcare in general. So overall, there's this tremendous feeling of mistrust. They feel judged by nursing and provider teams via stigmatized language and accusatory statements and tones. As far as your words go, I encourage all of you to, when we're done with this, not during the other speakers' talks, but Google words matter in addiction medicine and refresh your vocabulary, because we use a lot of negative, hurtful words in our fields. Individuals are afraid of losing their infants. They're afraid of losing them via mandatory reporting, or losing them because they're afraid they might kill them with their use. They're afraid that they're going to hurt their infants by taking their medication for opioid use disorder or by not taking their medication for opioid use disorder. They feel very uninformed about their care and their infant's care. They're fearful that their pain's not going to be treated if they have a C-section or if they have any other type of pain. They're receiving mixed messaging from healthcare. So on my end, for me, you're doing the best thing you possibly can by taking your medication for opioid use disorder. It's the best thing you can do for your baby. But then in the hospital, if their baby develops NOWS, well, you're on this medication, you did this to your baby is sick because of you. They're also receiving mixed messaging on breastfeeding. If somebody is not actively using and is on buprenorphine therapy, they should be encouraged to breastfeed. So these themes all resonate with Christy's story, and then also with published quantitative studies and qualitative studies. Education surrounding OUD for the entire healthcare team will reduce that stigma and strengthen patient-centered care. This will ultimately lead to improved mother-infant Dyad outcomes. And if we work together, we can help break this cycle of use and trauma for the next generation. So thank you so much for all you guys are doing. Next slide. Any questions that I can address right now? I have to jump back into clinic, so won't be on at the end.
Feel free to come off mute if you have a question. And if not, I've got your email, so if more questions come up, I can shoot you an email.
Perfect. And then if you want to share the presentation to an email, that's fine. There are a lot of really great resources on there. If anybody is starting their journey and just digging in to this topic, that can be really helpful. Just one last point, again, if any of the providers out there are looking at bringing this into your practice and prescribing medication for opioid use disorder, the two resources that were most helpful for me in establishing my practice were the provider clinical support system, which is created by a huge host of the heavenly bodies of medicine. It's a great tool. And then also the CA Bridge program, cabridge.org. That's a group out of California that is really navigating this world and have created beautiful patient and provider resources that are free for your use and are invaluable.
Kendra, I do have a question.
Oh, go ahead.
You were talking about how mothers are afraid of losing their infants.
Yes.
So like if they're actively using, like we do have to file, you
Correct.
know what I mean? We're mandated. So
Correct.
how?
So if they're, so that is one thing. And we've looked into that too here at Project Recovery. So if somebody comes to us and seeks treatment and they are actively using opiates and we start them on medication, they are in treatment. And oftentimes by the time that the baby is delivered, they're in early remission. So that should be taken into account. Yes, we have to mandatory report if there's continued use during the pregnancy other than the medication for opioid use disorder. But if they are moving forward in their recovery journey and are treated with the use for the use disorder, that is something that we don't have to continue to report.
So we report on when we get a MEC screen back. And if it's positive for anything, we do have to still report.
For buprenorphine or any other drugs?
I believe it's both. I can check in further.
Okay, and that's certainly something I would recommend you work with your individual social workers and hospitals and legal, because if they're on a prescribed medication, there shouldn't be any type of repercussions at that. Again, we do discuss with moms too that, you know, if there's the polysubstance use disorder, for example, if someone continues to use meth during pregnancy, we do have to report, yet at the same time, we're still completely 100% caring for the mother and the infant.
Okay, because I know we have a hard time too where we have to reach out to the provider to see if they have not been abusing even the prescription for opioid use. And we never really get a response back from our providers.
Okay. So I can't speak for other providers. That being said, in our team, we try to work very closely with any of the teams with moms and babies. I'm not sure what the options are in everybody's individual areas, but there's also another South Dakota state program. It's called Renew. Renew is an excellent resource to help mothers navigate their recovery, as well as help with some of those legal issues as well too. So we do have true discussions with the moms that this may result, especially if they continue to use, but if they're completely engaged in treatment and doing well in their treatment, there is no indication that they should lose their infants.
Okay, thank you so much.
You're welcome.
Any last questions before we let her go? Okay, well, thank you so much, Dr. Joswiak. And
Thank you so
I'm sure
much.
we will be asking you to come back to deep dive into some more topics. But
Sorry
thank
about
you.
the power failure. Thank you.
Oh, no worries. That's why I have you send the slides and we've got a backup.
All right, have a great day.
You too, thank you. All right, so next up, we are going to hear from Lindsay Carlson. She joined CHAD in 2021 and oversees the development of delivery of high quality programs, training, and technical assistance provided to health centers across North and South Dakota. Prior to joining CHAD, Lindsay served as the Director of Quality Improvement at Horizon Healthcare, and they were serving 21 communities across South Dakota. And Lindsay is an incredible quality improvement professional, and we are so lucky she's on our PQC leadership team. And so I'm going to let her talk to you about some quality improvement.
Awesome. Thanks so much, Morgan, and excited to be with you guys today. I've got 10 minutes to talk about QI, so we're going to run through this.
You can take some more time if you need.
Okay.
I can shorten my data.
Okay, well, I'll do my best to hit the high points, and yeah, we can have opportunities to keep talking about this with one another. So just quickly to talk a little bit about what is quality improvement. You all are familiar with QI. You have those QI folks at your health systems who probably pester you a little bit about quality data and all those sorts of things. But really, when we think about quality improvement, CMS defines it as the framework used to systematically improve care. That quality improvement seeks to standardize process and structure to reduce variation, achieve predictable results, and improve outcomes for patients, healthcare systems, and organizations. So certainly that's a shared goal of all of us as we do the work through the PQC and in other aspects of our care delivered at our health systems. One of my favorite words as I look at this definition is really systems. So when we think about quality improvement, sometimes there's this temptation to think about that we need to improve people, right? That people need to do things differently. And I think when we really put on our quality improvement hat and think about the framework, it's really focusing on how can we develop systems that really achieve the outcomes that we're after. And that requires us to define what that outcome is, which is certainly part of quality improvement, and then systematically work to make changes in our processes until we get to that desired outcome. So the improvement science that we're going to look at today is the model for improvement. There's two parts to the model for improvement. The first, the top half here on the slide, is really focused in on developing goals, understanding how we're going to measure our progress, and then thinking about what changes can we make to our healthcare systems that will result in that improvement that we'd like to see, that we set out as our aim. Certainly, that's where you start with improvement work. We've got to be clear about what our goals are. Through the project with the NSDPQC, you guys have some goals set forward for you. And so today we're not going to dig in so much to kind of the top half of the model for improvement. We're really going to talk about how do we do PDSAs? How, when we've got a goal, when we know what we're trying to improve, when we've defined some measures that we're going to use, and I have some change ideas, how do we really iterate, test ideas, and study results? So we're going to have a tiny bit of interaction here. Hopefully you have time for this. So if you all would just take a quick minute and take your cell phone, scan the QR code, or you can go to slido.com and then enter this number. I just want to check in, and I think it's really good. PDSA work takes a lot of practice, right? I even found in the health center where I worked that if it had been a little while since I had really done a PDSA, I had to kind of reorient myself. And so once you get the QR code scanned and you've entered that number on Slido, we'll start this poll. So what I'm curious to learn is, when is the last time you've completed a PDSA at your health system? So take a few minutes to vote. Thanks. I'm glad some of you got connected. That's good. Awesome. So the results are still coming in, but lots of folks new to this. And so that is really exciting. So today is just going to give you a taste of how to start thinking about plan, do, study, act cycles and improvement science. Some of us are a little rusty, but we've done it before, right? And for those of you who have done PDSAs this month, you guys get the gold star for today. So, and feel free to chime in or type in the chat if you've got ideas as we're moving forward. But appreciate everybody sharing their feedback, and we've got lots of variety. And so use that as a strength in this group too, use each other as resources and to share ideas. All right, so we're going to spend just the next 6 minutes or 7 minutes talking about what are PDSA cycles and how do we really think about implementation. So one of the things when I do trainings on PDSAs, it's hard to kind of think about it in the abstract. And so I put together an example PDSA for you, and we're going to talk that through too, because I think it helps bring it home a little bit. But first we'll talk about it in the abstract, and then we'll dig in kind of to some specific ideas. So when we're doing PDSA work, PDSA, of course, stands for Plan, Do, Study, Act. And it's really a very systematic way for us to identify change ideas, to test them on a small scale, to understand what happens, to really make sure that we're analyzing results, and then to decide what we're going to do next. Many times in PDSAs, we'll find out, this change, this thing we tested did not result in the outcome that I was after. And if we're doing our due diligence and improvement science, we should say, we're not going to do that anymore, because we don't want to ask people to do things that don't result in the outcome that we're after. And so when we do PDSA work, we iterate, we do things quickly, we test data very rapidly so we understand the impact of our changes. And then sometimes we scrap it and we say, oh, that didn't work, we're going to do something else. And that's exactly the intent of PDSA work. So P, when we're planning, we're going to plan our test of change. You have to kind of, you guys are all your healthcare providers. So, thinking about objectives, questions, and predictions, the scientific method probably comes really naturally to you. And I think you can use that to your advantage. So as we're thinking about a test of change, we're going to develop an objective. We're going to ask a question, and then we're going to make a prediction based on what we expect the outcome to be. Then we're going to punch through the details. Who's going to do this? What exactly are we going to do? Where are we going to do it? And when are we going to do it? And again, we're going to think small. We're going to think about something that we can do this week and then see what happened. And then we're going to develop a plan for collecting data. It's really important when we're doing small tests of change that our data collection is scaled appropriately. So we're not talking about complex data collection here. We're talking about something that we can really simply collect and see, so we can just understand if what we're doing is making an impact. Next, we're going to do the test. And we're going to do it again. I can't say this enough times. We're going to do it small. We are going to ask ourselves what happened. We're going to look at the data we collected, and we're really just going to have kind of honest conversation about what are our observations, what happened when we did this test. And then we're going to get more strategic, and we're going to study the results. We're going to talk about what we learned, how did what we predicted to be happen compare with our results, and then with the goal of getting to act. And then we're going to make decisions about how our PDSA test went and what that means for the next thing we do. So first, we're going to say, are there changes we should make? Likely there are. If it's your first cycle in a PDSA project, you're going to learn some things that you want to do differently next time. And then you're going to test again. That's called adapting. You also might, if you get really lucky, your change works and you're just going to adapt the change. So then you're going to scale. You're going to say, okay, this test worked with these 3 staff members. It worked really well. So now we're going to roll it out to the whole department. So we're going to scale it up. Or we might find out that something didn't work like we thought it would, and we don't think we're even going to adapt it. We're just going to scrap it, and we're going to try something completely different. So here's our applied example. So this is screening for SUD. You guys are all working to increase screening, substance use disorder screening for patients who are pregnant or postpartum. And so we have our aim statement. This is an example, right? When we develop aim statements, we want to have a SMARTY aim statement. So we want to be specific, measurable. We want our goals to be achievable too, time bound, and then equitable. So the IE in SMARTY is inclusive and equitable. Let's make sure that the work we do impacts the populations that we really need to impact. We've got our measures. So I used one of the sample measures that you guys are all working on. And then I just thought of some change ideas. You're going to have your own change ideas for how to improve screening. But these are just a few that I thought of and a few that I thought would be helpful for illustrative purposes. So maybe we decide the very first thing we've got to do if we want to increase SUD screening rates is we've got to do a really nice job of training our staff on the substance use disorder screening questions and documentation requirements. And so that's maybe where we're going to start. Another, the previous presenter talked about language. I think the more we learn, right, the more we understand how much our words matter. And so maybe the next step is to really train around how do we get comfortable about asking the SUD screening questions, and how do we make sure we're asking them in the right way to patients so that we get to our desired result. Or maybe there's a technology component to our change idea. Maybe we're going to implement a screening alert in our Epic system, and we're going to do it at these timeframes so that staff are reminded to complete training. All of these kind of separate and distinct change ideas, and so they would need to be tested independently, right? So we would try one, we would look at the impact. We might try the next, or we might try something different. And so just thinking about this, taking this to really the plan stage. So if our objective is to increase the percentage of pregnant and postpartum patients who are screened for substance use disorder, our question might be, will training staff on the SUD screening protocol increase screening rates, right? That's what we're hoping to understand. And we make a prediction. So we're going to predict that training staff on the SUD screening protocol will increase the percentage of pregnant and postpartum patients who are screened for SUD, which is what we're after. Some tasks and how we might think about those. This is meant to illustrate like how very specific you have to be in doing PDSA work. Because if there's not clarity around who's going to do something or what needs to be done, our work can kind of fall apart in the planning stages. So be specific and make assignments. So our clinical director is going to select the SUD screening tool. So we know there's different screening tools. We're going to ask our clinicians to pick which one we're going to use as an organization. Then we're going to do some training on that SUD screening tool. Our nurse manager is going to handle that training. We've got to leverage our HIT team in this process too, because we can do screening, but if we don't document it in a way where we can capture the data, it's going to be hard to measure if we've made change. And so that becomes an important part of our PDSA work. And then we're going to do the staff training, right? So all of these pieces are parts of our PDSA and our planning. Next, we're going to look at what data we're going to collect. We have kind of our overarching goal measure, which is the percentage of patients screened, and that will be a component of data. But it's also important when we're doing PDSA work that we think about a measure that ties directly to our test of change. And so in this case, right, our test of change is we're asking, will training staff increase SUD screening? And so the process measure I want to make sure I'm tracking is the number of staff trained. If I start looking at my data collection and I'm like, oh, you know what, nothing is happening. And on the other side of the house, I find out, oh, it's because we actually didn't get that training done, or the training was pushed out several weeks. We need those data pieces together to understand impact. Next up, we're going to do our test of change. And this is all just made up data, of course, for purposes of our example. So we did our staff training. It was delivered on March 10th, and we trained 10 staff on the SUD screening protocol. We asked the staff who received the training to begin the SUD screening. And here's a little bit of our feedback. We had a couple staff members indicate they were uncomfortable asking the questions. And another staff person had shared that a patient who they asked the questions to, they had a really negative response to being asked. All of these things I think could happen when you begin SUD training. And so I thought this was feels like a likely scenario, right? And then we are going to look at our data. So that's what happened. So that's all good input for us. And then we've got this data. So week by week, again, we're looking at small data points to see if something worked. Our staff were trained the first week. We had 8 SUD screenings complete that week and out of 10 visits. So we had 10 prenatal visits and 8 of them accomplished screening. Oh, great. That's an 80% screening rate. The next week, you can see the data, you can see a little bit different data set. Oh, our screening rate went down a little bit. It rebounded a little bit in weeks 3 or 4, right? So we're going to look at this data as a team and we're going to think about what can we learn? One of the questions I might ask is, let's look at these charts and make sure, especially for week 2, was there a documentation issue, right? So is our workflow working? Are people putting data in the right place? I might also say, we had a really good screening rate that first week. I wonder if staff forgot over time, or they had that negative experience and it made them less likely to ask the next time because they were worried about the patient's response. And so there might be some things we could dig into to better understand as we look at our weekly data. And then we have to know, did the change result in improvement? So we see some improvement in screening rates. There's a few things we could do here, right? You might train more staff. You might say, you know what, overall, we see like that our screening rate is trending in the right direction. And so we're going to scale this. We're going to train more staff. We think that this is going to get us to our result. We might adapt our change. So we might say, we're going to train more staff, but when we train staff the next time, we're going to use a script. And that script is going to emphasize that we ask these questions to all patients. And so that people don't feel like they're maybe being singled out by asking these questions. And so we're going to do that. We do another PDSA. We track the change in the same way. Or we might find out that, maybe your screening rate was higher than the 80% that I shared in the data. And you're like, oh, that didn't get us to where we wanted to go. And so we're going to try something new. That wasn't the right test of change. But always, PDSAs are iterative. They build on one another. And a lot of times it takes a few different change ideas to get us to our results. So we end up layering training with something like an alert, with something else maybe that we hadn't thought of yet, but we learned along the way. Just a few things to kind of leave you with as I wrap up. One, start small. Do short cycles, think of a week and think of what you can test in a week. Think about process versus outcome measures. It's important that we can understand how frequently or how reliably our test of change is happening for us to really pair the results, right? So I have to train staff to understand if my staff training is resulting in increased screening. And so make sure you're testing both of those sides of things. And then it's okay if things don't work. Just don't keep doing things that didn't result in improvement. So that's why we start small, because it's easy to change course when we do things on a small scale and with just a few staff or a few providers. And that is what I had for today, Morgan.
Thank you so much, Lindsay. It's always good to have some good quality improvement, and we might be hitting you up with some questions as we get into like our QI calls in between learning sessions, and if hospitals need a little bit of extra help with their PDSAs. But thank you for coming and sharing with us.
Yeah,
and does anybody have any questions while Lindsay is here? Okay, well, let's move on. I will save my data piece to the end because Dr. Stephanie Foudy is here, and it is her time to speak. She is a family medicine physician who provides comprehensive care for all ages in Devil's Lake. She has a special interest in women's health and obstetrics, and in her free time, she enjoys spending time with her family, reading, crafting, and baking, and participating in community events. Dr. Foudy, do you want to go ahead and share your screen?
Yep, sorry, Zoom and I are having a little disagreement.
You are just fine. I know you just got off another meeting too, so thank you.
Let's see. Maybe I'm going to share my screen. Okay. Are you able to see my screen?
Yes, I see the
presentation.
presenter's side, not the
Yeah.
presentation side. And that's okay.
We might stick there because I don't know if it's gonna let me switch. There's no
No
notes
worries.
or anything. It's not gonna be that exciting, but
You're good.
all right. So like Morgan said, I'm Dr. Stephanie Foudy, family med in Devil's Lake. I have been providing MAT treatment. It'll be 2 years in June since we started providing that here in Devil's Lake. For All True as a health system, we've had a couple NPs that have been providing it in our Minnesota clinics for a few years. And then our residency program has actually started doing that within the last year. And so I'm going to talk about policies more in a little bit of a general sense, not necessarily specific to substance use disorders in pregnancy, but just in general. And then I can touch a little bit on things that we are working on as far as policy procedure for pregnancy itself and substance use disorders in pregnancy. So one of the first things is getting your team together and figuring out what your goals are. Are you just going to be, what type of medication and treatment are you providing? Are you just going to be doing the buprenorphine? Is it going to be oral injections? Are you looking at setting up a methadone clinic, which is a whole nother ballpark, which I do not do, so I'm not really in a position to talk about it, except for to say it's a lot of work. You have to have a lot more specifics, and it has to be through government approved and a bunch of different stuff. Or do you choose to do both? Are you going to include alcohol treatment for that in your treatment or not? Are you going to just treat opioid use disorder, substance use disorder, or are you going to treat chronic pain, or both? And how many prescribers are you going to have? So when we started in Devil's Lake, we decided that at least at the beginning, we were going to only use it for, only use buprenorphine for opioid use disorders, unless there were issues in pregnancy. That was the one exception that we made, is if we had a patient on chronic narcotics for chronic pain, that we would consider at least doing MAT treatment for those patients during pregnancy. The other thing that we had decided, we are a 16 provider clinic, 6 physicians, 6 APPs, that we would have a minimum of 3 of us that would be prescribing if we were going to launch this program. And that really has to do with vacations. Now, that has become a little bit better since the X waiver is going away. However, you still have to have providers in your practice that are willing to do those refills. And we've actually run into that a couple of times with our Minnesota clinics, where they only have one provider who does MAT, and that has become a challenge, and really reaffirmed that, like, we were thinking correctly when we decided we needed multiple people in one location to be able to do that. So that really is the first step, is figuring out what your goals are. And really in Devil's Lake, this started, it was a little bit of my brainchild. We had gotten discussions from Spirit Lake Clinic, Can-Do, which is about 30 minutes away. They do MAT, and they were getting full and had a lot of patients driving from Devil's Lake. And so one of the hardest things is getting buy-in from your providers to prescribe it. And so I'm happy to talk to anybody if they're wondering. Really what I did, I reached out to some of my physician mom groups on Facebook, and was like, who does this, and is it awful? Because that's kind of everybody's fear, is that your practice is going to be inundated with these people who are difficult to work with, non-compliant, and that is going to ruin your practice. And when I reached out, really, I had about 95% of people who responded to me actually talked about it in a positive light. And is it challenging some days? Yeah, it is. But honestly, when you get people in the program and they're committed and they're going on, it's also very rewarding. So it's finding the right people. And I would also just add that I don't believe in requiring people to do this. Not everybody should provide addiction treatment, whether for personality, personal things, history. So I definitely do not recommend making this like a required thing that people have to do, because that's not good for that prescriber, and it's not good for the patients that they're taking care of. Step 2 is to pick your people. So I was trying to go through my entire list and figure out, like, who all is involved. So at Ultra, we actually have an MAT work group that meets monthly. And so any person who prescribes or is interested in prescribing buprenorphine or providing MAT is invited. We have a few nurses that are on there. And when you're setting up policy, you want to have your nurses involved. You are going to need some administration. There is going to be some policy and that kind of thing. You're going to want to have lab staff for your drug screens, IT, and legal. There are some interesting loopholes and privacy things that are a little bit more challenging to work through with substance use treatment. And briefly, it's basically taking the privacy of drug use or substance use treatment with the Cures Act, which basically is like release all the information. So they do kind of butt heads. So you want to make sure that you have legal on board as you are coming up with your policy and procedure. And then really, I kept this super simple, like literally 3 steps, but it's, you know, a little more involved. And then is use your resources. So SAMHSA has a lot of resources for policy and procedure, and it really being in the Midwest. Little Falls, Minnesota, there's a couple of family medicine physicians there who are now boarded in addiction medicine who really kind of set off a now very robust program for narcotic addiction. And they're always very willing to share their policies and procedures and different things. They are often the 2 of them. If anyone has ever seen like the opioid treatment boot camps and those kind of things. I don't know about in South Dakota, but at least in North Dakota and Minnesota, they are doing a lot of that. And then the CDC also has some good information. Other considerations when it comes to pregnancy is frequency of visits, what this means for, you know, delivery and education there. So what we have done, all of our patients, regardless of pregnancy status, sign a consent, a separate consent specifically to MAT. Our pregnant patients sign a second consent. And basically, and if anybody wants these, let me know. I'm happy to share what I have. But essentially it says that, hey, buprenorphine treatment in pregnancy is not without risk. However, it is less risky than continuing to use opioids or to try to withdraw on your own and that kind of thing. And there is robust evidence to back that up. The other thing that we don't have completely in place that we are working on with our residency program and one of our NICU physicians is a consultation process. Babies who are on buprenorphine, or whose mothers are on buprenorphine, are going to be more at risk for neonatal abstinence syndrome. And so we are working on a process that would essentially set up an in-person or a virtual appointment with a neonatal physician to go through those risks, to kind of give a little preview of what a NICU stay is like, and to have these parents as prepared as possible. We already know that a lot of people who are experiencing addiction really struggle with change, and a lot of times have adverse childhood events or some other trauma that they are coping with via their addiction. And so it's ideal to have them prepared for these potential complications to their treatment, as opposed to having them thrown onto them at the last second, say, oh, sorry, your baby's withdrawing, you have to go to the NICU, and have them not know that that is something that is a potential. So in Devils Lake, there's 3 of us that provide buprenorphine treatment. 2 of us also provide OB care. We have a couple patients that see us for everything. So we do their OB care, we do their Suboxone or Subutex, and we have some that want to see their regular provider who they've seen for their OB care, and then they just consult for their Suboxone or their Subutex. So there's not really a right or a wrong way to do it. I mean, really the biggest things is, you know, when you're looking at policy, you want to decide on what you're doing for drug screens. Is that going to be required or not? Are you going to require or recommend certain amounts of training outside of what is already recommended federally or statewide? And then are you going to require like the number of visits, or are you going to leave that up to your prescribers? And it's a little challenging because everybody likes to do the things their own way. But it's also important to make sure that there is consistency among your practice, so patients are receiving the best care that they can. And pregnancy and addiction is challenging. I have patients, I actually have one who just delivered that I literally saw every week. I have one currently who is pregnant and I'm supposed to see her every week, and she sometimes shows up every other week. So that's the other thing, is you do have to have a certain amount of not just compassion, but of flexibility. Your patients are going to show up late. Sometimes they're going to forget, they're going to, do this and that. And you really have to be willing to kind of meet them where they are. And if that's something that doesn't work for your practice, then you should probably be considering if it's the right avenue for you, or, looking into your resources to say, hey, this patient needs treatment, but who can do it? Because not everybody should be providing opioid addiction treatment or any addiction treatment. So I am open to whatever questions. Like I said, if there's anybody, we are in the process at Altru of finishing up our policy and procedure. I actually had it mostly done, and now have to make changes due to the X waiver requirement going away. But if there are specifics or anything that anybody wants, just let me know and I'm happy to share those. And that's all I got.
Thank you so much, Dr. Thoughty. Does anybody have any questions? And thank you for taking time out of your clinics today to come and present. Okay, I'm not seeing anything in the chat, and I'm not seeing anybody coming off of mute. So now our next speaker is Professor Thomasine Heitkamp. She is a Chester Fritz Distinguished Professor Emeritus and Behavioral Health Research Specialist at the University of North Dakota. She is also a licensed clinical social worker in the state of North Dakota. Professor Heitkamp is passionate about contributing to efforts to support the current and future behavioral health workforce. She has trained extensively and published on the topic of behavioral health stigma and brings 40 years of expertise in rural social work practice. She has administered SAMHSA-funded training and technical transfer centers in support of workforce development, and she's presented at our September in-person conference, and I'm so happy that she has agreed to come back and share again because she has such great information. So Professor Heitkamp, I will turn it over to you.
Thank you so much, Morgan. Pleased to be with you today, or pleased to be back with you. I will talk a little bit about stigma today. Do you want to share my slides, Morgan, or should I?
Whichever you prefer.
If you want to put them up, that'd be fine, and click through them. I'll have you do it. I did send them in, and
Yes.
just feeling a little humble by all the really strong presentations. And I don't know if Dr. Thoughty has left us or not, but just a huge shout out to the physicians that have picked up this work in medications for opioid use disorder. When I started with the Addiction Technology Transfer Center in 2017, we were working in states with hardly anyone waivered. There was hardly anyone doing medications for opioid use disorder, which we called medications for addiction treatment at the time. But it's good to see all this really good work that's happening in our healthcare systems to support moms who are pregnant, to support these families, and to really expand the addiction science in our practice. So you can go to the next slide. Thanks, Morgan. So I've been asked to talk about stigma. I would say it's the one thing that I always talk about when I talk about addiction science, because I think it's the biggest barrier. And Dr. Thoughty just mentions many times, both directly and indirectly, the importance of the relationship. And not everyone's cut out to do this work. And I think she might have been alluding to people that hold stigma about people who use drugs and alcohol. So stigma is really complex, right? It's complex attitudes, beliefs, behaviors, and structures that interact at many levels. So to address stigma, you're looking at individuals, groups, organizations, and prejudicial attitudes about discriminatory practices against people with mental and substance use disorder. I include mental health disorders, but I would say the research is very clear that stigma is far greater for people with substance use disorders. So next slide, if you can move on, Morgan, thanks. So here's the deal. Here's why we have to care about stigma. We have really bad outcomes already for people struggling with substance use disorders. You know, SAMHSA, we haven't moved the needle like we'd like, and that's the federal agency, Substance Abuse and Mental Health Services Administration, that really works to build addiction science and mental health science to our practice. But only about 10% of the population who have a substance use disorder have any kind of specialty treatment. And in the research that I do, we see that those outcomes are even tougher in rural areas because of the lack of providers. So, and then access to high fidelity practices. All the practices you're hearing about today are high fidelity practices. So, you know, it's important that we share the slides, we share the recordings, and we get this information out. You know, rural centers are more dependent on public dollars. They have fewer wraparound services, and they have less access to counselors. And there's a term for this that I find interesting. It's called structural urbanism. And the reference sources are in these slides, but you can look that up and you can see that, you know, when we're talking about North Dakota and South Dakota, we're primarily talking about pretty rural areas where, you know, if someone comes late to Dr. Faudi's treatment, maybe they've driven an hour to get there, and that might be why they're late. Maybe there have been bad roads, and this is a hub. So there's lots of reasons why we don't have as good of outcomes. The other thing is we just have a terrible workforce shortage, and rural areas suffer even more from that. And the pandemic didn't help that. So next slide, Morgan, please. So what are some of the reasons that people don't get treatment? You know, I think that Christy talked about this in the first presentation today. You know, kind of that denial, or I'll get sober tomorrow, that you know, denial of the problem. And maybe they can't afford care. Maybe they can't step away from employment. Maybe they're worried they'll get fired. The lack of readiness to discontinue use. And what we're going to be talking about today is those stigmatizing attitudes that are held by people that make people not want to tell the truth, that make people not want to identify themselves. And I know you're going to hear from Kim Miller about screening, and screening is very important as well. So just want to do a shout out for the next presenter. So self-stigma, people hold these same attitudes. I'm bad, I'm unworthy. I would say the common denominator in the work I've done clinically and the work I've done as an educator and a professor is the shame. There's so much shame associated with use oftentimes. And then there's just a mistrust of treatment. You know, you hear this. I know they went many times for treatment and it didn't stick. You know, you'll hear those kinds of things. So, but oftentimes we don't talk about diabetes or hypertension, which are also chronic diseases in the same manner. And part of that is the stigma of addiction. And people don't know where to go. Next slide, please. So there's three types of stigma. There's self-stigma, and I alluded to many pieces of that just now. There's public stigma and there's structural stigma. Where I put my time as an academic is primarily in the structural stigma area. So that's the piece I like to talk most about, because as you're working in healthcare systems, think about, you know, those pieces that become stigmatizing. As someone said to me, I don't want my waiting room full of addicts, right? Well, that's a structural stigma, right? And, you know, I gently explained that your waiting room already has people that struggle with substance use disorders, and maybe they don't want to talk about them with you because of those attitudes. I didn't say the last part, but I did think the last part. So next slide. So self-stigma, I mentioned shame, low self-esteem, the kind of why try cycle, right? The lack of engagement in treatment. How do we get to treatment? What kinds of treatment are going to work? I want to do a shout out for something that I'm seeing occurring along with medications for opioid use disorder, that expansion of harm reduction models. So a lot of the self is identified with many times poverty. The people that you're going to serve live in poverty. They maybe don't have reliable transportation. Maybe they don't have reliable internet. Maybe that engagement and treatment feels so overwhelming, especially for moms who have little ones at home. And so all those pieces put together, plus the stigma, it can so easily feel overwhelming. So as healthcare providers, if you can start to peel back that onion and take away some of those barriers, because you know there's already that self-stigma. How do you take away those barriers and remove that stigma? How do you say as a provider when someone says to you, I've been using, thank you for being honest. Let's talk about that. It doesn't mean tomorrow won't be better. Giving hope, that really is a big piece of it as well. Next slide, I'm going to talk about public stigma. I'm always struck, I'm going to confess to this group, I'm a big TV watcher. I tell everyone that. I love television. I think it's a great escape. But one night I decided in my TV viewing, because I watch all kinds of things, to look at how many times people were drinking. And this glamorization of drinking on television, right? But at the same time, we have this, you know, all these bar scenes where people are drinking highballs and shots. And at the same time, we have this public stigma, right? And so they don't quite match. And so the media really plays into that, right? Stereotypes, prejudice, discrimination by the general population. And, you know, isolation and rejection. We see that in a lack of housing, lack of supports, and sometimes generally lack of attention to harm reduction. You know, if someone's using methamphetamine, you know what the public should do? Support them by giving them some water, a quiet space. There's small things we can do as a public with education about substance use disorders and supports. And then we engage in coercive practices, you know, the lock them up, right? We see so many people with mental health and substance use disorders in our prisons and our jails. And it's costly. I think prisons can do some good work. I'm not saying they can't, but it's really costly. And is that the best place for them, right? So the focus of change really is a different messaging, a different education, different community programming, and contact strategies. And what the authors will tell you, it's really helpful. You know, what we just heard about peer recovery supports from Christy Johnson, that is really powerful. I've heard her speak before, but I can't get enough of that because it reminds people recovery is possible. Next slide is structural stigma. And this talks about discrimination, laws, policies, you know, the things that when people are doing a urine analysis, how do you do that with respect? Think about that in your healthcare systems. What kind of housing employment law creates problems? Again, I mentioned poverty because I think it's really critical that we think about this. And this population of women who are pregnant, people who are pregnant, you know, it's pretty scary. It's really scary to start talking about your addiction and your use during pregnancy. Lots of risk, lots of risk. So I would tell you the most critical piece of this that I want to leave with you is that relationship that you have, building that relationship of trust, giving that relationship time so that they trust that they can talk with you and you won't stigmatize, that you will hear them, that you will hear what's going on. And you will think in your head, this is a chronic disease. And I'm going to tell you, I didn't always think this way. I went to Vermont with a group of healthcare providers because that's kind of the mecca of expanding medications for opioid use disorder. And I'll never forget an addiction scientist at that meeting. It was an addiction physician, which as we expand that saying, you know, if someone comes in using for treatment, we just don't treat them. And he said, well, if someone came in after a Big Mac and had been diagnosed with diabetes, would you refuse to treat them? And that was kind of my moment where I thought we treat chronic disease of addiction differently. Now, I'm not saying if someone's intoxicated that they're at a place for treatment, but what I am saying is this locking people out of treatment because they might be periodically using is not something that's going to be successful. So next slide. Thanks, Morgan. So what exacerbates the problem? Stigma, lack of culturally appropriate care. It isn't just stigma. What's going to work for people? There is not one size fits all as we look at treatment. Things that might work for one person, and I've seen harm reduction work. Someone starts with harm reduction and says, I'm not going to use meth, but I'm going to smoke grass, right? I'm going to use cannabis. And then all of a sudden they're saying, well, I'm not going to use cannabis and I'm not going to treat cannabis like a harm reduction. you start them on a path with small pieces of success. And then, just you live with some of the past bad practices. And this is a great group. You're at the training, we're kind of speaking to the best audience in some ways, but knowing that they hold those fears. What are those fears that they hold of acknowledging that substance use? And then some of those stereotypes. Again, the meaningful therapeutic relationship. Next slide. So words matter. I think you got the link. Morgan, I think we put the link in. It's in this slide as well to Words Matter. This is the easiest place for you to start if you think about debunking stigma. Use person first language, right? A person with a substance use disorder. You're not an addict, right? He's an addict. She's an addict. That person has a name. That person has the right to that, the type of engagement that would make them feel like they have value, because every person has value. Junkie, person in active use. Alcoholic, person with an alcohol use disorder. I just laid these out so you could easily see that. Instead of former addict, person in recovery. Person who's previously used drugs. You hear a lot of this. They're clean, they're dirty. It's testing negative. And I'm not saying that you need to be the word police. And there's times when people use these terms that I don't go, whoa, 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 right? And especially if it's someone who has supported people who are abused substances, is in treatment, is a 12-step program. So all those pieces really become complicated, but as professionals, healthcare and human service professionals, these are terms that I would suggest. Babies aren't addicted, they're baby with neo-abstinence syndrome or newborn exposed to substances. So those words matter. Next slide, I would just add one more thing as we go to Q&A. I don't know how many of you know Dr. Larry Bird, and I have absolutely the highest regard for his work. And he started working in fetal alcohol syndrome disorder about 40 years ago when I met him. He's been doing research. And the other day I was at a healthcare facility on behalf of my husband, and I ran into Larry. And I promised when I do training that I would do a pitch, don't forget alcohol. Please don't forget alcohol. It's so toxic, it's so difficult, and he's not feeling like he's winning the battle on the alcohol front in terms of use during pregnancy and use in society. So I don't know if there's any questions. You want to take down the slides, Morgan? Appreciate you sharing them.
Yes, thank you so much for coming. Does anybody have a question? You're welcome to hop off mute or drop it in the chat. Okay. Oh, all right. Well, thank you so much, Thomasine. I enjoy hearing you every time we get the chance to have you speak. Our next speaker is Kim Miller. She is a UND graduate with a master's degree in counseling. She has over 30 years of experience in the field of addiction and mental health. She is a licensed master addiction counselor and a licensed professional clinical counselor. She is also the director of Addiction Counselor Training Consortium for UND. And Kim enjoys walking her dog, traveling to warmer places, so do I, and spending time with her family, especially in this like never-ending winter that we seem to be stuck in. But Kim, I will turn it over to you. Thank you.
Okay, so let's see. I want to share my screen. I'm hoping we get this. Well, then I need to, wait a minute.
We can see it.
You can see it, but I need to be able to see it too. So I know where's my, okay. The presenter, my view. Well, I don't want to share that. Oh gosh. I had this all, wait a minute. Now you're seeing, okay. Black art. I want. Okay. Are you still seeing anything?
Nope, it stopped sharing.
Okay.
When you push share, you can click the presenter view of the PowerPoint, and then the presentation view should show, and then the presenter view with your notes and things should still, you should still be able to see it on your screen, but we wouldn't see that.
Right, I know, I'm trying to,
Okay.
it had done that earlier. And
It
now
always seems like you have it perfect, and then
I
when
know,
it's
I had it
time-
and then I ran into trouble with it. Okay, I
no
wanna,
worries. So we see the presentation view right now.
yeah. But. And it's, okay. There's subtitles, and not the only thing I wanted. What the heck? No, I don't want that either. Ah! I need to stop sharing again. Stop share. And go back into.
I do have the PDF version you sent me that I can pull
Yeah.
up and share if that would be easier.
Okay. Ah. No, I don't want that. Okay. Maybe what I need to do is X out of it and reopen it. No. Like I said, I had this all done and now we're already behind, so.
Oh, you are just fine.
And it, yeah, because it's not allowing me to X out of it either. I don't know how I did this. Okay, well, I'm going to start talking about it, and because I'm going to be discussing screening and screening tools. There's some key points to this, is that this is screening and not making a substance use disorder diagnosis. So that's what's important to remember here. So I wonder if I need my task manager.
I have it up unless you want to try to share.
I'm going to end it and then I'm going to reopen it.
Oh.
There we go. And then I'm going to reopen it and get started again. So that is going to be the important thing, is that this is about screening. The expectation is not that you're learning how to make diagnosis today. Okay, and we're gonna go back to slideshow from beginning. Ah, now I got it. And then where's my, okay. All right, minimize that. Okay, there. Share that. And then I need to, where's my, make this a bigger screen. More. Oh, dear God. Okay. Chat participants. I don't want to stop the video. I just want to make this go to full screen. Oh, okay.
We can see your full screen presentation. Is that what you're wondering?
Yeah.
Yeah, we can see your full screen.
Oh, that's. And then I just. Okay. I want to see. All right. Well, we're just going to go. Okay. So again, why are we going to look at screening for alcohol? And what we look at it is that when you go in for a healthcare visit, you know, I'm used to being questioned about seatbelt use and other kinds of behaviors that relate to my lifestyle. We do want to make it just part of a conversation that we screen for alcohol because there's so many other health issues that it might be related to. Thomasine was just talking a little bit about, you know, Dr. Bird and his concerns as far as how alcohol, you know, there's that general sense that it's not a big deal. And what the studies have shown is that screening and brief interventions can reduce drinking levels. Early detection can reduce greater harm, and asking about alcohol or other substance use can help an entire family. Here are some of the basic evidence-based screening tools. You can see them here, and I'll go into just one or two of them in a little bit more detail as we go along. Audit C is either a 3-question screen or a 10-question screen. The CWA is more commonly used for detox settings, social detox. And then we have some of the old ones here, the CAGE and the MAST. Now, CAGE is not something that we encourage people to use anymore, but I know when I first started working, a lot of the doctors asked about eye openers and morning alcohol use. The MAST is a self-report that's commonly used in treatment facilities when people come in for alcohol or drug DUI assessments, and they will hand out a MAST, and it kind of is supposed to let people know if they have a substance use disorder or a concern that needs to be further reviewed. So here are the 3 questions for the audit C. Very simple. How often do you have a drink containing alcohol? How many standard drinks containing alcohol do you have on a typical day? And then how often do you have 6 or more drinks in one occasion? So you can see it's just, you know, how frequently are they using, to what extent, and then, of course, asking about binge drinking without asking about binge drinking is basically what it is. Because if you ask anybody, oh, do you ever, you know, binge on alcohol, likely they're going to say no. However, if you ask them, how often do you have 5 or 6 drinks in a setting, they may be more open to, you know, giving you an answer. So if there's a yes to one of these questions, it might just be, you know, some concerns. If you're getting more yeses than nos, then again, that's indicating there might be some risk there. And of course, we have the biological tests and devices for alcohol detection. Breathalyzer tests are not used frequently in a medical care setting as far as like for prenatal checkups that I am aware of. And we do have the urine testing. There's the ETG testing that has been used for testing for the metabolite of alcohol. And it will show whether somebody has used alcohol within the previous 72. There are some that will actually detect it for up to 96 hours. And so there's not a lot of efficacy to using breathalyzers or even the urine drug screening. People will respond. You know, it's more likely that they will tell you yes or no versus, you know, basically relying on like a breathalyzer test. I mean, that's great for DUIs, probably not so useful when you're meeting with somebody and planning prenatal care. So again, just affirming that healthcare providers should be doing screening as part of just a normal conversation with their patients. We also suggest school counselors, other mental health providers, law enforcement, and court people. Okay. I need to find there it is. And here's some additional screening tools. There's the NIDA quick screen and then the 4 Ps. And so that has, I think you said we're going to send out the slides in the PDF. And so you can access that. And here are the 4 Ps. The first one asks about parents. Did any of your parents have a problem with alcohol or other drugs? So this gives you an idea if there's any family history of substance abuse disorders. or substance use within the family system, because a lot of times we do find, I think Thomasine mentioned ACEs, or one of the other presenters mentioned ACEs, is that there could be a family history of it. And some people are aware of it and are aware of those risks. And some people just think, well, that's just normal. That's what our family does. The second P is about the partner, and asking whether their partner has a problem with alcohol or drug use. Again, what kind of exposure do they have to that in the home? Asking about the past. Have you had difficulties in your life because of alcohol or other drugs, including prescription medications? So they might have had some issues when they were younger, which sometimes during pregnancy, they may be at risk for using or abusing, or depending on what their situation is. And then asking about current use. In the past month, have you drunk any alcohol or used other drugs? There's another one, it's even shorter, and this one focuses on other substances besides alcohol, and it includes a question on marijuana. So this one is the SERP P, and that also I think should be in the notes that I sent, asking about marijuana use. And that's very important at this stage, with more states that have legalized social or recreational use of marijuana, medical use of marijuana, and just, a lot of people have the mistaken idea that it's a safe substance to use during pregnancy, when all of the research that we've reviewed and that we've discussed in other trainings is that there's no amount of marijuana or alcohol use that is considered safe during pregnancy. And asking again about how many drinks you've consumed in the month prior to knowing you were pregnant, and asking the question about, do you feel the need to cut down on your using, whether it's alcohol or other drugs. So the key takeaways is, again, any of our folks that come in for medical care should be screened for alcohol or substance use. And you can't rely on just, their age or whatever, thinking that some people are too old. And we've got a whole series on substance use in older adults. So I'm just kind of putting that out there, is that just because somebody looks like your grandmother doesn't mean that they can't have some issues with substance use, particularly if they're using other prescribed medications, and the risk of some fatal interactions if they're not educated on how alcohol, or even, there's some old hippies out there that decided that it was time to go back to smoking pot too. So it's something to be aware of in your medical practice. And there are different screening available tools. And again, I sent those to Morgan. And there are a couple of them that have some good validity and reliability and are appropriate for that population. Screening can reduce harm. And again, it's not going to determine the presence of a substance use disorder or an alcohol use disorder, but there's a lot of studies that have shown that even when a healthcare provider asks the question about it and kind of talks about what the risks are of using alcohol or other substances, that it can by itself reduce risky use of those substances. And so again, screening can be done in a variety of situations and settings, and I think it's a good thing to have as part of the conversation when you're working with people. Obviously, if they're coming in for prenatal care, hopefully you're going to continue seeing them on a regular basis, and this, opens the door to continue that conversation, because it may come up in postpartum care as far as if they want to use alcohol in their breastfeeding, or if they're thinking that getting a medical marijuana card will help them cope with postpartum depression. I mean, there's a lot of instances where being able to have this conversation will be very important, for both you as a provider of their care and for them, to make healthy choices. So I think there's some other additional links for SBIRT. That's the screening, brief intervention, referral to treatment. There's a whole series of recorded trainings on that on the ATTC website. And then again, the audit, that's a 3-question one that I went through. And then there's an additional one, craft, and that's more for families. So I believe that is the end of my slides. And I don't know if there's other questions. I believe if there's
If
questions.
there are any, we can come off mute or drop them in the chat. We have one last presenter we need to get to. I know we are running low on time. We've had so many wonderful speakers.
Sure.
And if there aren't any questions, I'm going to hurry and just introduce Rebecca Hahn. She is a social worker at Sanford Fargo with Maternal Child Case Management Team. They provide case management services to FBC, NICU, PEDS, PICU departments, and previously she has been a case manager for people of all abilities and a child protection worker. And I don't want to take up any more of your time, so Rebecca, I will let you go right ahead.
Sounds good. I know you were going to share my slides, I believe. Perfect. I'll make it quick, guys. Truly, this is just to get some conversation going and kind of make sure we're aware of our services here at the hospital. So truly, my department I work in is case management. With that, you might have also heard of social worker, social services. We truly are trying to find that blanket of case management and utilizing that terminology, as we have discovered patients are more comfortable with that. And so that is us. If we want to switch slides. So what do we do? Truly, as a case manager, we do a little bit of everything. If there's a question out there, we're not sure how to get the answer, where to go, come to us and we'll try and investigate that for you. But truly assessing, that is our criteria here. We want to assess, meet people where they are and kind of figure out what's going on in their lives and if there's anything we can do to help support them. Resource are trying to figure out what do we have in our communities that can be helpful for our families, guiding families into the right connection, because we all know how daunting it can be to be given a list of 20 different resources and where do we go, what's actually going to help me, and it can make them feel defeated. So we're here to connect them with what's appropriate for them. Facilitate, so just making sure we're facilitating communication and then coordination of services, and of course advocate, so just making sure that we're kind of advocating for all and protecting. Next slide. Okay, so when to consult us. I know this looks little, but truly we can be consulted at any time for any needs. The big significant ones are going to be regarding any concerns of maltreatment to an unborn or born child or live child, assessing any social concerns that are arising, or if there's truly just any needs out there for a family that they need to connect with community resources. So if a family's speaking with you about things that aren't really offered in a hospital setting, connect them with us, and we would love to have an assessment with them, figure out where they're needing to get connected, and happy to help them. Next slide. The big thing here is about mandated reporting. So especially with children or mothers that are pregnant, if we've identified that there's any concern of using any alcohol, illegal substances, or anything like that, as medical professionals, we are mandated reporters. So if we learn of information, it is significant that we report it. I threw on here a couple things of like North Dakota, we have a centralized intake, we have their phone and their fax. South Dakota also has a centralized intake. And then Minnesota, they do it a little differently, where you reach out to every county specifically for where the family resides. Now, with reporting, we are more than happy to help as a case management team to get this done with you, hear what you've had to say, and get the reporting done. So that way, we're the ones that utilize the system quite a bit, and we're used to connecting with these community partners. Something to be aware of too, if we have patients that they live on a reservation, we will be connecting with that specific tribe versus connecting with a county or a different state. But in the end, if you have any concern, just making sure you report. And North Dakota Centralized Intake, they are great with file a report to them. If that family does not live here in North Dakota, they will forward your report onto the appropriate county or entity. And if we truly are in an emergency, so this typically more happens when we have like the PEDS PICU side or even the NICU. Once a child's born and there is an immediate emergency, immediate risk to a child's life, we would be contacting our local law enforcement for intervention versus reaching out to CPS first. Okay, next slide. And then Child Protective Services. So with our moms that are pregnant, we do have what's called a pregnant female assessment. So, and I know I'm more familiar with the North Dakota side of things, of what they offer for services in the child protection realm. But with a pregnant female assessment, really they're there just to kind of do the same thing as case management. We're here to hear your story. We're not judging, blaming, shaming. We're here to listen, try to offer services and get you connected. And then outside of that, if use continues and a mother has given birth to a child, we would have to report that, of course, if we have a verbal admission or a positive UDS, whatever it may be. And then at that point, that assessment would be called a substance exposed newborn assessment. With this, there's just different options, but this program is designed to help new mothers get connected versus going into a straight traditional assessment where there could be findings and significant impact to employment and different things like that. Then also traditional assessments, anytime there's a kiddo that we report on, if CPS deems it's appropriate to get involved, and they'll do a traditional assessment and just see if they can connect the family and help them grow stronger. Next slide. So truly, I know my slides are short, but really our goal is to assess, connect, and protect. We're really here just to be the, hey, how can we be a helping hand? Let us, if we identify that there's a family that maybe needs some extra support, let us get involved, let us assess what's going on, see if they can connect in any way. And hey, for that protection, let us help with the reporting, or we'll do the reporting and help in any way possible. So yeah, I guess if you have any questions, go ahead and ask. I know that was a very brief and quick overview of just case management.
You ended right on time, even though we took up some of your time. So thank you so much, Rebecca. If anybody has any questions, you can come off of mute. If not, we are at the end of our 2-hour block. We had some of our initial data to share, and we will do that when we do our QI monthly calls that will be starting next month. So day-to-day leaders at your facilities, be looking for an email from me next week on a scheduling poll, and we'll split up our hospitals into smaller groups and talk more QI specifics. And we have about 42% of our hospitals have reported data for the first 3 months. And so I will also be reaching out to those hospitals who have not reported yet. And that's okay if we're still trying to figure out the best way to collect the data. We want to work with you, so don't make it feel like it's a scary thing. We want to help support in any way we can. Thank you everybody for being here. A huge thank you to our wonderful speakers who have taken time out of their day to share their knowledge with us. This meeting is being recorded, and this and slides will be shared. Probably early next week, we'll send out an email and it'll be on our website. And we are at the end of our time, so have a wonderful day. And if there's any questions for any speakers, send them my way, or if you have their emails, connect with them, and we will do our best to connect you with the answers that you need.